Hi, good afternoon once more. We're going to talk now about a topic for which I would like the clicker. I was so moved by the song that I forgot the clicker. Thank you so much. So a little bit about do's and don'ts about cervical spine trauma. This is a topic very dear to me because I began my career as an emergency physician in the EMS setting. In Brazil, we have that Franco-German model in which we have doctors in the pre-hospital setting. So I began my career, even before I did my residency, as SAMU. So I really loved this stuff, you know. You get to the patient right there on the street in the middle of the night, you know, and you save that patient. That's amazing. So when I found out that most of the stuff that I did actually was hurting the patient, my world kind of fell apart. And I'm so sorry that if this lecture is going to give the same feeling to any of you. So, about immobilization. Immobilize everyone, do the spine clearance, use corticosteroids, and intubate. Which of these is do's and which of these is don't? Don't immobilize everyone. If you work in the ED, you have seen it. The pre-hospital guys, they come in and they go like, oh doc, I didn't even think this patient should have been immobilized, but you know, it's protocol. No, it's not. There's no such protocol of immobilizing everybody. They have to have some kind of criteria. And when I say that it says so in the Bible, I am of course talking about the ATLS. I've heard this. ATLS guidelines are not really guidelines because there's no such thing. ATLS is just a course. It has been confounded with ACLS, which comes with a guideline, but the ATLS is just called, albeit a revolutionary concept, a great course, not mandatory for emergency physicians, but in general, for my PGY1s, the first year residents, I recommend that they do. And it's a good course, but they are famous for being out of date in their information. So it's a course, it's just a course, there are no actual guidelines. But the American Heart Guidelines, surprisingly enough, do mention cervical immobilization. We'll get to that in a minute. But the most important, I understand the rationale behind wanting to immobilize everyone. It's like this, there may be a benefit, and come on, it's harmless. That's the point of my entire lecture. It's not harmless, and I can prove it. It's not harmless. Putting the cervical collar on, it's probably hurting your patients much more than helping them. So you have to select the patients. So I was surprised to see that in the 2015 American Heart Association guidelines for resuscitation, they actually went out of their way to talk about cervical collar. And they go on to say that this evidence, combined with concern for potential secondary injury due to neck movement during attempts to apply a collar, has led to suggestion against the use of cervical collars by first aid providers. And when they talk about weak recommendation, they're talking about the types of study that they had, the low quality of the studies, and that is a fact. We have no actual clinical trials on immobilization that can help us make most of these decisions. They are made with healthy volunteers and are observational studies. So these are just the abstracts of some of these studies and some of the stuff we have to think about. There's no, not even a shadow of a doubt that when you put the cervical collar on, you're going to increase your patient's intracranial pressure. And it's kind of paradoxical because if you have a patient with a traumatic brain injury, it's almost mandatory to put in his collar. But know that this is increasing his intracranial pressure, and this might hurt your patient. Also, there are the pressure ulcers related to the use of collar. Over 24 hours of use will put your patient in a high-risk group for developing these, we can lead to infection, which can really harm your patient. And the most important thing, it's the airway management. It really hinders your movement. It's really bad for you. And it has been proven also to cause hypoxia in healthy volunteers. So we have an abundance of evidence, although not from clinical trials, none of them showing differences in mortality. Okay, but all of them show bad things that happen when you put the collar. And they go on to talk about extrication and probable injuries associated with the placement of the collar. And this makes me question, what goes on our minds when we fear so much the cervical spine? Because if a patient comes to you and says, look, a ping pong ball hit me in the arm, I think it's broken. If you can contain your laughter, you're not going to give him an x-ray. That's preposterous. It's not broken. A ping pong ball? Yes. But when it comes to cervical trauma, we're like this, we have some magical thinking in there, you know? We are afraid. It's like you have like a ninja bone or something. In the minds of the people, it's like the cervical spine has been shattered and you have a ninja bone waiting. As soon as you move your patient without the collar, you're going to paralyze the patient. That's not how it works at all. Actually, in the pre-hospital setting, when we approach the patient and he has his neck like this and he's lying on the ground, what do? We bring his neck to the neutral position, and the ninja bone already did its job. So that's what we have to do, is move as little as possible, without any paranoia, without any cervical phobia. And then when you get patients with primordial conditions like ankylosing spondylitis, you may ask, what is neutral position? Because his column is like this, cervical is like this. If you try to put it in neutral, you're going to break it. And this study shows exactly that. So, this one study, again, not a clinical study, but around a proof of concept. These German guys, they did this. They created a simulated scene in which the patient was going to be extricated, like after a car accident. So they put various sensors on the patient's neck, and these cameras, they can actually detect the movement, okay? So they devised 6 different types of extrication. Only one of them was without a cervical collar. It was the control group, of course. In this, and each one of the techniques had a little bit of a difference. Like, you put the cervical collar on, rotate the patient 90 degrees, and in other technique, you put the long board behind the patient, and each one of these techniques had a little bit of a difference, and they wanted to measure how much you're going to be moving your cervical spine, okay? So, in the control group, they had this set of instructions to the patient. The patient is alert, and it has no sign of confusion or intoxication, all right? So you begin by talking to the patient. Can you understand? Well, I'll do this. If you feel pain at any moment, you just tell me, all right? So stop at any time. So put your right foot in this place, put your left foot in this place, get out of the car. Self-extrication, that's the control group, right? The patient's not going to be touched. We're just going to talk to them. And this is smart, because, you know, the patient is going to feel pain if he has something wrong. And if that does happen, you should immobilize it. What is surprising is the result of it. Which of these techniques moved the cervical spine less? The control group. The control group. If you don't fiddle around, if you don't play with the patient, if you dispense of those theatrics, the cervical takedown, the collar, the long board, you're going to move less the spine. So it has been proven that you are hurting your patient, maybe the cervical collar doesn't really help, and it probably is the worst way to take a patient out of a car. So, saying that, you should have enough things to say to the EMS people when they come to your ED, and they go like, oh, it's just protocol. You can go like, not exactly. That protocol of immobilizing everybody does not exist. So, but it already happened. Your patient came in immobilized. Now you have to clear his spine. This is a do. Be good at this, because you are going to help your patient. You're not going to leave him there lying on the hard, long board of that uncomfortable cervical collar, and you are going to avoid hypoxia, intracranial hypertension. It's just good sense. So let's talk a little bit about this in a non-specific way. As I've said in my previous talk, I don't like to use my two hemispheres to memorize things. I use a third one, my cell phone. These two hemispheres, they are for thinking. So search for the app, to check on the things if you are forgetting something. You don't need to memorize this. This is silly. But let's think about it. You're going to clear the spine off without any kind of imaging from patients that are fully alert and that are not intoxicated, because you can't trust the patient that is kind of comatose, GCS of 8, GCS of 10, a Glasgow Coma score. So he has to be no drugs or alcohol, has no abnormal neurologic signs, of course, because if he does, well, that's a big indicator that he might have a lesion. And no auto-distracting injuries. It's like you can't really talk to a patient with a severed arm. So, and this age limit, it's just a thing of the actual papers, so you can, it's relative. If you have a patient that's older than that, but it has a good function, and has, it's fit, you can trust it also. So, just from thinking, just from common sense, if someone falls from elevation and he has axial load to his spine, if he's ejected from his car, if the car rolls over, those are dangerous mechanisms. I would be worried. It's one of those things that come to DD, and when they start to describe it, you go like, oh, really? You just listen to the story from the EMS. You want to get more information about the accident itself and not the patient. And these, if he gets to tell you, well, we got to the scene and the patient was walking, so we did the cervical takedown, we went there and put long board behind him, and immobilize him fully, only his eyes moves now. If he was sitting at any moment, or if the pain in the neck was of delayed onset, it's probably muscular, of the contraction from the moment of a simple rear-end collision, for instance. So these are the dangerous mechanisms, and these are the low-risk mechanisms. If you hear some of these, you say, this patient is low risk. If you hear some of these, you're going to say, no, this is dangerous. I may have to get some imaging. And so just so we get this out of the way, if you are working in an ED that has CT, you're going to use CT, all right? And if not, you get the 3 X-rays to try and clear that with something around 96-97% sensitivity for fractures or unalignments. That will permit you to take or not the collar. But if the patient does not have a dangerous mechanism, if he has a low-risk history, and you go and examine him, you take the collar off, immobilizing the cervical, and you palpate the midline of his neck. No pain, no pain. Now you ask the patient to rotate his head some 45 degrees to the left and right. No pain, no pain. You take the collar off and you do no imaging. Don't worry about that, all right? If you ask for imaging in this setting it's going to be as useful as this one. I have no use for this, you know. Let's talk a little bit about corticosteroids. It's not really a thing. Stop doing it, you know. It's a real don't. Although it is the only medical therapy that was ever proposed to spinal cord, traumatic spinal cord injury, what we have of evidence, the guidelines, the societies, it's no longer recommended. There is a tiny little bit of population of patients that may or may not benefit from it, but if you ever do it, remember of the correct dose. It's a huge dose of corticosteroids, and it will increase the chances of your patient getting septic. You're in the trauma setting. The patient already has lots of reasons to be infected. So just to clarify, this is one of the guidelines published in 2013, and that clearly states, based on 4 blinded, randomized trials, that there exists no medical evidence of benefit. And there is some evidence of worse outcomes in terms of infection. Also, the Canadian Association of Emergency Physicians says the same thing. I only got the abstract of this paper. There's insufficient evidence to support the use of high-dose methylprednisolone. It would be used in the first 8 hours. Then when would you use methylprednisolone? In the following setting, if I am in the first 8 hours of trauma, and if the patient is deteriorating neurologically. If he's deteriorating, if he's getting worse, this is something that you can do, provided you are in the setting that can approach that lesion. If the patient is going to be transported to 12 hours later, be operated, probably there's going to be no benefit in that, all right? So, to sum up, intubation of these patients, this is your chance to avoid secondary damage. And this is what you have to avoid: hypotension, hypoxia, and wasting time and wasting money. When I say about wasting time and money, I'm talking about immobilizing this patient fully before intubating. Forget about this. You're going to hold him with your hand, just as simple as this. Your first attempt is going to be your best attempt, so it's going to be your only attempt to intubate. Never, ever, ever try to intubate this patient using the cervical column. So you're going to go to the head of the bed, of course, but you're going to have your assistant placed in this position. Manual inline stabilization, which will provide you some safety of this movement. So it's going to be held up like this, and this movement is not going to happen because of this. And what about, it's the lateral movement. About the anteroposterior movement, well, you're going to avoid that by gently manipulating the airway with your laryngoscope, and you should be able to use a bougie. If you can't have a good look at it, don't try to put, maybe your first attempt should be with a bougie already, you know. So you're seeing the tip of the epiglottis, you slide that bad boy in. But if you have available, nothing beats the video laryngoscope in terms of not moving the cervical spine, all right? So these are my do's and don'ts of the spinal cord trauma. I appreciate a lot for the opportunity. Thanks.